Hey everyone, this is Nick here with DentalRx. Really excited to be bringing you guys the finished product here for the DentalRx platform. Early access is going to be starting next week, and all the early access users will be getting emails with their login information later this week, or this coming week, I guess. And pretty excited to get started with you guys, get some feedback, and improve the system. For those who didn't get access or haven't signed up yet, we'll be opening another round of early access signups in November for access in December, and that will be coming up, so make sure to keep an eye out on either LinkedIn or on the DentalRx website at dentalrx.ca. So today we're going to be going through a patient case to showcase all the modules within the DentalRx platform. The patient case is theoretical, but something that you guys might see in your clinics once in a while. So we have a 91-year-old female with a history of mechanical heart valve replacement and renal disease. Patient's taking warfarin 5 milligrams daily, ramipril 10 milligrams daily, metoprolol 25 milligrams twice a day, as well as furosemide 20 milligrams daily. Patient's not on any other supplements or over-the-counter medications, and we confirm this all verbally as well as using PharmaNet through services such as Medinet. When we talked to the patient, we also asked for her weight and serum creatinine so that we could assess this, her renal function as well. So she said she was 90 pounds and her serum creatinine was 80 on last lab visit, and her INR as well was 2.9, which has been stable. So first thing we'll do is we'll go to Dental Med Dictionary. We'll look up the patient's medications. So we'll look up warfarin, ramipril, metoprolol, as well as Lasix, just to show we can search by the brand name. We'll analyze these medications, and then we'll come down here. You'll see we can take a look at the drug itself, the use in class, the interactions and dental pearls. In this circumstance, I want to draw your attention to the fact that we should be monitoring for intraoperative and postoperative bleeding, and then for their blood pressure medications and heart medications, we can potentiate renal failure with NSAIDs, and also we're going to want to be monitoring their blood pressure as well. So we're going to go to our not prescribing monographs first, but we'll take a look at the practice guidelines. There's a couple guidelines we're going to be wanting to look into here. First is anticoagulation, and then we're also going to want to look at antibiotic prophylaxis for this patient. So we're going to look at anticoagulation first. We know the patient's on warfarin, which is a vitamin K antagonist. And we see that medication alteration is only indicated when the patient is newly started on warfarin or has a history of labile INRs. And we know the patient's INR has actually been stable, and it's been stable in an appropriate therapeutic range, which is 2.7 or 2.9, which is what the patient told us. So we're not going to have to modify the patient's warfarin, but we are going to want to think about their bleed risk, and think about as well, they're going to be at higher risk because they do have renal disease. So we might want to think about local hemostasis methods, such as gelatin sponges and tranexamic acid mouthwash as well. So we're going to go now to our clinical calculators. And the reason we're going to go to our clinical calculators is so we can calculate their renal function. So we're going to put the patient's weight or age in, their weight in pounds, which was 90 pounds. We know that they're female, and then we're going to put their serum creatinine as 80, which is what they told us. So we see that their creatinine clearance is 25.5, which is something that we need to note down. just on the threshold of, getting into mid-stage renal disease. And now we're going to go into our prescribing monographs. And we're going to take a look first. So we're looking at the antibiotics for endocarditis prophylaxis. And we're thinking, hey, do we need to adjust anything for renal disease? And in this circumstance, the only time that we adjust for renal disease is when it's an abscess. And endocarditis prophylaxis, we can just give the 2 grams prior to appointment. So we're happy with that. And we're going to think as well, if they're getting a 3rd molar extraction, they're probably going to be in a reasonable amount of pain after the operation and have a reasonable amount of swelling as well. So usually we'd give something like acetaminophen or ibuprofen to keep the swelling down, and maybe a narcotic as well if there's going to be a lot of pain. In this circumstance, we're thinking maybe acetaminophen is appropriate, and we see for renal disease there's no adjustment necessary, so we can just give the standard dosages, 500 to 1000 POQ6H-PRN. For ibuprofen, we're thinking maybe to keep the swelling down, but when we go to kidney disease, we see that if the creatinine clearance is less than 30, we shouldn't actually use it, as it can cause an AKI. So we're going to avoid that. Now we're thinking, could codeine work? Again, we go to kidney disease and we see if their creatinine clearance is less than 60, there's an increased risk of toxicity. So lastly, maybe we're thinking tramadol might be helpful for them. And we see if they have kidney disease, we can actually just decrease the dose. And with our knowledge of pharmaceutics, we also know that there's a combination product called Tramoset, so we can combine the acetaminophen and tramadol together. And in this circumstance, we'll give the 37.5, 325 milligram tablets, 1 to 2 tablets every 12 hours as needed. And we'll probably provide 3 to 4 days of that. So we're good with our pain medications. And then we're also thinking that we should be giving hemostatics, and we should probably be using a oral anticoagulant hemostasis dose of 10 mils of the 5% rinse for 120 seconds prior to the operation, and then QID PRN 1 to 2 days after the operation. We can also go here, take a look at any pearls, contraindications, any interactions, are they at any of these risks? And then lastly, we can see what might be covered with the Canadian Drug Benefit information. And we see that we might actually have to compound this rinse at the pharmacy and get that covered through the pharmacy, and whether the clinic would be willing to pay for that or not. So that's all looking good. Our last thing is maybe there's going to be some swelling that we have to take care of since we can't prescribe NSAIDs. So we'll look at dexamethasone. Is there any adjustments? Not for renal disease, which is good, so we can go with the standard dose. And then last thing that we would do is, now that we've collected up all of our prescriptions, we would go to our prescription templates. In this circumstance, we would go to preoperative and postoperative, or maybe antibiotics for the endocarditis prophylaxis. And in the future, we'll be making custom templates as well for everybody to make for their own practice. But at this time, for early access, we won't have this feature available, and it will be coming hopefully for the second round of access, which again, signups will be in November, and then access will be in December. So I hope you guys are excited for the DentalRx platform. That was a brief overview of essentially all the modules and how you'd go through them for a patient case. If you guys have any questions or wanted to give any comments or feedback on the platform, feel free to message me at the admin@dentalrx.ca, which is email, or you can fire me a message on LinkedIn, as I check that pretty frequently. So again, hope you guys are excited. Launch is in a week, and I hope to talk to you all soon. Thanks.